All right. Thank you for joining us tonight, Dr. Grant. I'm going to make you the host, but while you're kind of pulling up your slides, maybe you can start by explaining how you kind of got interested in the study of Chiari and syringomyelia, and how you came to become the chair of our board. Talk a little bit about that, and then you can go ahead and start your presentation, and I'll come back at the end.
Great, Caitlin. Well, welcome everybody. It's really great to be back with you all. I haven't done one of these for quite a while, since I was at Stanford, and now I'm at Duke, and I was at Duke before, 10 years ago. So it's really fun to be back, kind of where I was for many years. And I still go back and forth quite a bit to the West Coast, so kind of go in between. But it's been great to be associated with Bobby Jones, and I've been affiliated with them for quite some time. They really have a mission to bring together scientific collaborators from now around the world. We really tried to pull globally to get the best out there to really start partnering together, and learn how we can improve the quality of life, for patients with Chiari and syringomyelia. So it's something that I've been very passionate about for many years. Back training with Dr. Ellenbogen in Seattle, University of Washington. He had a large interest in this area, did quite a bit then with MRI and cine flow studies. And that's where I really developed my interest under his mentorship. And I've continued to stay very closely linked to many of the foundations and to the patients and to the science of how we could do better, how we can improve the surgery, how we can improve outcomes. And again, back to the quality of life, because that matters the most. It's not the imaging, it's really how we could, over years, get these children and adults to be the best they possibly can, and also to promote the truths in terms of where we are at, and dispel some of the myths about Chiari. There's a lot of social media, of course, around this area. It's a tough science, particularly when the diagnosis is based on imaging and not symptoms. And much of the work that Bobby Jones is doing is to really redefine Chiari, and in this modern era, that it's no longer just the imaging. We need to do better than that. And like other diagnoses, they have rounded out to focus on the patient and what the symptoms and signs might be. It's the same with Chiari, and I hope we can move in that direction. And I'm very proud to be associated with the scientific advisory board for Bobby Jones, and that's been just an amazing team to work with to try to advance the field. Sorry, long answer, Caitlin, but that's why I'm here.
Okay. Are you able to share the screen?
Sure. Can you see this?
I'm learning about your brain.
Karen, you're unmuted.
So I'm just going to give a brief presentation. I'm not going to get too involved in this. I didn't want to bore you over too long. There's a lot of questions that came through, which are really exciting, very engaging questions. So I hope we can focus more on those. But I just wanted to kind of set the stage for some of these areas of interest that I think it might be kind of fun to think about. It's very interesting at Duke because I could see patients across these ages. And Stanford, I was much more predominantly on the pediatric side because you have these children's hospitals and the adult side. And if any of you are treated at these different centers, it is harder, particularly with transition of care. What happens when you turn 18, 21? There's a tough migration to the adult side. And some diagnoses are presenting, in the pediatric age for Chiari, and some are more on the adult side. We don't understand, why that is. And so that's some of the science to try to understand that a little bit better. But it's always been an interest to me. Is this the same disease? The symptoms might be a little bit different. the child versus adult. And at Duke, I've been really happy with the fact that the age doesn't matter in terms of how I see the patients. It's been just one health system to kind of see, the newborn to the elderly. And it's been really interesting to start thinking now what we can do across the span of age, for Chiari. So imaging has always been a very important area. As I said, the diagnosis for Chiari is very strict and based on imaging. We have very strict criteria, right? We always look at, this is Chiari I, and there's also 1.5. Common area of discussion always is, does 1 lead to a 2 or 3 or 4? And the answer is no. So Chiari II is a very different entity, related to open spina bifida. And that's a very clear diagnosis that is less common than the most commonly diagnosed, which is Chiari I. And there's different variations of Chiari I. You'll hear about Chiari 1.5, there's Chiari 0.5, there's Chiari 0. There's all sorts of permutations of severity, and we can talk about that if you want. But this is the classic Chiari I with the tonsillar descent, beyond this magic red line of about 5 millimeters or greater. But a Chiari is not a Chiari, because sometimes you see the tonsils have descended, but there's quite a bit of room around them, versus something like this, which is a really crowded appearance of these tonsils next to the spinal cord and brainstem. And this whole area of the back of the brain, you see lots of findings that I always look at very carefully with families. You don't just look at the back, but you look at how the skull base is formed. You look at the odontoid, the C2 bone. You look at basilar invagination. How high is this bone? You look at the angles of the skull with the spine, and you look at the morphology of the brain and spinal fluid flow. So this is something that with imaging, we get better and better at this. And sometimes it gets even more complicated where you get this kind of bubble of the brainstem that forms, which is really going into more the Chiari 1.5 malformations, which we think are more serious and more likely associated with syrinx and symptoms. So we're always trying to differentiate that, which I think is an important distinction personally. This is a topic which has always interested me. There are patients that present sometimes with unilateral symptoms, and it's being reported more and more because when we think about a Chiari diagnosis, classically on imaging, we're looking at the midline. The midline area is where we see the spinal cord, the brainstem. We can do our measurements. But remember, the tonsils hang on one side or another. And if they're severe enough, you'll see it in the midline. And that's why, by convention, we often look at a midline for the MRI scan, where you can see the syrinx, you can see the spinal cord. But sometimes the tonsils are quite asymmetric normally. One side will be lower than the other, which is normal. And even at surgery, we find that one side is very low and much bigger and almost eclipses the other tonsil, just like this case where you're looking straight at the head and the neck, and here is one massive tonsil and here's a little one. So you can see how this one can look so prominent on the side view, but that's coming from one side. And this unilateral Chiari is something that definitely can lead to a syrinx still. You can have that compression of the brainstem just from that one side alone. And what's interesting is you try to make sense of these symptoms, because there are many reports of, say, facial weakness on one side in a patient with a Chiari. And is that linked? Sensory loss on one side of the face, hearing loss, unilateral hearing loss with a Chiari. Now you can say, oh, that's not related, and I used to say that because I didn't know, but to be honest, you start seeing these case reports where the patient had surgery and the hearing got better. So that makes you wonder about this. And that's where I started opening my mind to some of these things that we really have to think carefully. Are these related or not? Trigeminal neuralgia, this is where it's severe facial pain from the fifth nerve. Hemifacial spasms, severe pain in the face with spasms from the seventh nerve. Double vision, this is more common. I've seen this from pressure in the brain called pseudotumor, and you can see a sixth nerve palsy or from the hydrocephalus. You sometimes have patients with a third and fourth nerve palsy. I had this last month. Is that related to Chiari? So we have to be very thoughtful about this. It's not a slam dunk, but I just wanted to bring this up because it happens in the clinic more and more now. We're being asked, is the Chiari the cause? And I've definitely opened up my mind to start thinking about these more because the films are so asymmetric on the same side of the problem, such as hearing loss. The other area that comes up quite a bit in the clinic, particularly in the pediatric age, is neck positioning and imaging, where the position of the neck is very important when you start looking at the tonsillar descent, whether you're in flexion, neutral, or extension. And you have to look at that carefully because if, say, a pediatric young child is asleep, they often put something behind their head and they're in extension often if they're asleep or sedated. But if you do it awake, they're more neutral. Or sometimes if they're awake, they put a nice pillow behind the head and you're in flexion. So if you're wondering why the tonsils keep going up and down, it could be just position. And that's something important to bring up. And that's been looked at, and we pay attention to positioning to really understand how Chiari might change over time. The other area, and that this is one of the questions that came up, is tonsillar descent by age. And this is a very interesting, there's a couple papers about this, of the position of the tonsils over the years of life. You can see first decade of life, age 10 to the 90s, just looking at MRI scans. Now, negative means basically below. So they're hanging below the foramen magnum. So this is more, the tonsils are lower, hanging down in the cervical spine. Okay, so negative means, lower down. So it may not be intuitive to think like that. You can see as you age, your tonsils move up. So they actually, well, in the 90s, they're millimeter or so above the foramen magnum versus when in the second or third decade of life. I thought this would be more prominent in the 30s or so because we pick up so many adult Chiaris in their 30s, particularly young women, but it was still more common to be lower, in the pediatric age. But there is definitely a change over the years. If you look at distance below the foramen magnum, you can see first decade versus the 90th, there's definitely improvement of the tonsils. So if you can imagine, you can diagnose of a Chiari, one malformation early on, it will disappear as you age just by following that patient if you're just going by strict radiographic criteria on the MRI scan. Here's another paper looking at position of the tonsils. Again, tonsil position. Now, this is the opposite where the tonsils are, well, they're lower down and then they improve, over time. And the dip here is where the tonsils were the lowest. So it's interesting that there's this change over time. Doesn't matter kind of exactly what decade we're talking about, but just recognize that there is a change normally in terms of the natural history of someone that has tonsils that are lower or higher relative to the foramen magnum, which is that red line that I showed you. And it's interesting, conclusions, female sex was associated with a lower tonsil position at every age, which is interesting. Most patients had a right tonsil symmetrically with the left, but the right was lower than the left more often. So just like I was saying, there's often this asymmetry and a right-sided predominance. So this is real, and it's something that we pay attention to. And last is that, there's definitely a question, and this is what we're really trying to better define. And Bobby Jones is doing an amazing job to gather the resources needed, to help us define over time, what happens with these patients with Chiari. Let's look at their symptoms. Let's look at their imaging over time. It's this whole natural history, we call it, that we don't have a good handle on. for Chiari. Most Chiaris, remember, are not symptomatic. Many don't even know they have it, right? But with MRIs now these days, we're picking these up more and more. So it's not an epidemic where all of a sudden we're seeing so many more. It's just the fact people can get imaging much easier than they could in the old days. But these are changes that we see. Here's a baby 2 weeks of age on the left, 6 years old. No Chiari. Here's the Chiari malformation. Well known that you can have an acquired Chiari 1 malformation over time. This child was not born with it, and here later at 6 became symptomatic and has a Chiari malformation. So that's something that's well known. Many families ask me, was this there since I was born? Is this congenital? We don't know unless you've had old films. There's no way to prove that because we see stable imaging, we see acquired Chiaris, and we see improvement of Chiaris over time. And I've published that over the years. If we pick up a Chiari malformation, one of my important sort of commandments is to image the entire spine once. And that's if it's a serious enough Chiari or I'm going to be following this Chiari, I really want to see their whole spine for a screening one time because we sure pick up other things that we didn't expect. And you want to know the whole story. We pick up fatty phylums, the fat, in the band that pulls the spinal cord down, or the spinal cord's not pulled down and we see fat. The spinal cord could be low. We see clear tethered spinal cords with something called spina bifida lipomyomeningoceles, fancy name for fat in the spinal cord. We see dermal sinus tract, say a baby with a little dimple on the back that has skin that's following inside and pulling on the spinal cord. And as that child grows, it can cause an acquired Chiari malformation, well known. And they become almost Chiari 2-like. Remember, they don't become Chiari 2s. That's the open spina bifida, but they get the same changes in the brain that look like Chiari 2, where everything just looks sagging and pulled down. This is something we published a while back of the Chiari 1 and tethered cords that we found. And this may seem common knowledge now, but back then, we didn't quite understand this whole thing, that we got to look down the spine and see that the spinal cord's going all the way down to the coccyx, all the way down to the bottom of the sacrum. No Chiari initially, Chiari developing over time, and the spinal cord here is low with the fat. So this is a real entity. And gosh, it's nice to know about this, right, early on. So I always image that spine, listening to the patient. I can't emphasize this more than anything else in this entire talk, is that I can learn so much by just listening to how these symptoms started, day to day, what they're experiencing, the headache patterns. We pick up migraines, all sorts of reasons for headaches, cluster headaches. How do we know they're Chiari headaches? Thinking about position and what position does, time of day, other associated symptoms of Chiari, tons of sleep questions we ask now. We never used to. And that was a lot of the questions too about sleep. I love those questions. So we got to listen to the patients, listen to their story. And you want them to be as accurate as possible, hopefully not tainted by Google, because that gets difficult when you have a list of 50 symptoms. It gets very hard for us to sift through what is really affecting you day to day that we need to pay attention to. And gosh, what would your life be like if you got rid of these top 3 things? Is it really worth it to you to undergo surgery, say, for that condition? Because surgery clearly has risk. An example of this is a patient like this that was involved in a low-speed, car accident, which, no symptoms before, had imaging, found to have a, pretty tight Chiari malformation, pointed tonsils. Tonsils go down about 8 millimeters. So a real Chiari 1, terrible headaches, horrible headaches in the back of the head, could not function, quit work, quit school, all posterior headaches. Again, listen to the patient. This patient had symptoms always when she was upright, always sitting up. Headaches got better when she was flat. And outside hospital, underwent a Chiari decompression. Looks beautiful, no better. Still terribly symptomatic. So what went wrong? Why did she not get better? You know, you'd think, well, looks great. Imaging's perfect. Good luck. No better. Can't get out of bed. And we got smarter, right? We're always thinking about CSF leaks that can happen with a trauma like this. And she had a leak that she just had a little patching done, very non-invasive patching. You know, Duke's a big CSF leak center, so this is something totally in our mind every clinic visit. We're thinking about CSF leak. Could this be a CSF leak? Because you don't want to miss these, because that simple epidural little fibrin patch of that leak completely resolved her symptoms. Now, did she even need the surgery? I don't know. She already had it before this, but you just don't want to subject her to those things if maybe she didn't need it because of that leak. And she told us this over and over about her positional symptoms. We just have to listen. We have to think about that and what that might mean. And you can get all sorts of changes in the brain on imaging and sagging and venous engorgement of the sinuses. There are tricks of imaging that try to pick up these low pressure states. We call it intracranial hypotension is the fancy name for that, as opposed to intracranial hypertension, which is the opposite. That's the pseudotumor cerebri. Now, if you fix these leaks, they reverse and they start getting high pressure headaches. So this is a difficult area to navigate. And some patients oscillate low and high. They're really challenging patients without a Chiari, but with a Chiari, it can cause even more problems if we have to think about pressure in the brain. Is this reversible? Well, can Chiaris get better on their own? You know, and all of us that treat Chiari, we have a handful of patients that, for whatever reason, we did not operate on. Maybe they presented some other way incidentally, and the family just said, no, they look so good. How can I commit to surgery? Or lost a follow-up, or, you know, who knows what, insurance, or we couldn't operate on them for some reason. Even the tight Chiari with a large syrinx like this and progressive scoliosis at age 10. Now, interesting, this kid was asymptomatic until he developed some terrible cough, like a viral illness, 3 weeks of coughing. And we imaged him and had this scan. His cough got better as we waited for his cough to go away, because I didn't want to operate on him until we felt that his lungs were safe. They thought he probably had a bronchitis, and there's a much higher risk of complications with anesthesia if you don't wait a given amount of time. Your airway is much more reactive with the drugs they have to give. So I said, well, this is now it's been a couple months. Let's just repeat the picture so you make sure nothing's changed, because he had this bad scoliosis. And here's his picture. And this continued 6 years. Syrinx completely gone on its own. Chiari's still there, no symptoms. Now he got some other coughs since then. I was like, oh no, here we go again. But imaging didn't change. So to me, this is fascinating. But it's also opened our mind to say, be careful. Don't assume anything, that kid had that syrinx for years. We don't know that. Maybe that was the driver of the scoliosis. Maybe it wasn't. And by the way, even though the syrinx went away, his scoliosis didn't get better, and that had to be treated. Another kid, 8-year-old boy with bad headaches, normal exam, very tight Chiari. Also, his ventricles were up because of the Chiari in the brain. He had a small syrinx, you can see, particularly going up and down the entire spine. MRI repeated in a year. His headaches got better with actually some Topamax, no headaches. So we watched him. syrinx went away. So we just continue to watch them. Why intervene? I can make the picture look better, but how can I make him look better? There's no argument here to do anything. And then last is a paper we looked at, typical kids. And the key is these kids were picked up on MRI for other reasons. So they might have had a concussion or something, and they get an MRI, shows a Chiari, and very tight one. And I watch it, say in the young kids, particularly very young, 4 to 5-year-old, and the Chiaris continue to reverse. You see the difference spontaneously on its own. Not an uncommon story in the young kids. So I particularly wait, and I'm very conservative for that very young population. And we looked at the posterior fossa, we measured it, we looked at volume and the mismatch, because it's always this question of shoe size and how big is the brain for that compartment, and things got better. So it's worth waiting, again, if they're not symptomatic, and we just do surveillance now with our quick scans, and we watch these improve over time. The kids who have symptoms and present that we're looking for a Chiari, they don't do this. They don't get better like this, and it's a whole different path. So those we end up unfortunately doing surgery. So I'll stop there, but I just want to give you a little bit of a preview of how difficult Chiari is, both in diagnosis, understanding symptoms, how they might relate to the imaging, and how our treatment is not so easy sometimes, particularly the judgment of do we operate or not. It may be safer just to watch, and particularly in the adult side, we're even more conservative, because I guess the concern is obviously you operate and you've opened up the door to many other potential problems that could develop. So over the years, if anything, I've gotten more conservative, actually, in watching Chiaris more, with a lot of good, careful surveillance. And these people are watched and carefully monitored, and they're in the clinic. It's not like, well, call us if there's problems. We watch these kids very carefully. But I just love to hear your thoughts, and I can go through the questions or whatever you'd like, Caitlin, to have to make this useful and a productive time. So thanks for the opportunity to be with you all tonight.
Absolutely. Thank you, Dr. Grant. We have a crazy amount of questions that I'm worried we won't get to all of them. So we might have to do this again at some point.
What do you mean? We have 6 hours. We're fine.
Well, sure. But kind of to piggyback off what you just mentioned about the surveillance, there were a couple of questions that I will lump together a little bit. Basically asking about how long and how frequent. So how often should someone have an MRI? Is it based on symptoms, and what symptoms would call for imaging? And then with a patient who's already undergone surgery, I guess it's a little bit of a different question. How often does that patient have neurological evaluations, especially if they're an adult?
No, great questions. And of course, a lot of this depends on specifics of what we're doing. Do they have a syrinx or not? Clearly, with the syrinx, we're going to be watching them for a while. Without a syrinx, and the pictures look great, patient's asymptomatic, doing wonderful, I still watch him for a couple years, him or her, but it's not years after that, because they really, at that point, are feeling pretty good. The kid can tell me if they're having symptoms. The parents are really good partners in that care, and I feel good that we don't need to just keep doing pictures. Although with the fast scans, these 2-minute, 3-minute MRIs, I've definitely lowered my threshold and do a lot more surveillance than I used to, because it's not the big scan. What I don't want to do, Caitlin, is put a child to sleep just for surveillance, when I think that's a bit overkill, because sedation's another risk. And we don't want to do CT scans, right, with terms of radiation. So the fast scans have been just so wonderful for these quick shot images, because I can see down to about C7 in the spinal cord, pretty low on some of these fast scans. And I get to look at the back of the brain, and I make sure the ventricles look okay. And that quick preview is great. On the adult side, things are more stable because they're not growing usually. Maybe we're shrinking, but we're not growing. And those patients, it's about a couple years after surgery. I just make sure they're not getting into any cerebellar slump or any problems developing or scarring that can cause syrinxes, even if they didn't have one. But they can tail off much faster because the adults will tell you and they have symptoms, and it's going to take us a lot to go back and do something, but symptoms usually would drive that decision. And therefore, I feel much more comfortable in adults, not imaging as often. And the last factor is the distance from care. We've often done a lot of telehealth lately and trying to keep patients close to home. And so that is a tougher to do the neurologic exam that you talked about. And we have to rely a lot on video, and that's more difficult, even if they're in state or some of the borderline states bordering to where you are. You can do that telehealth if you're licensed and all. So it's a trickier business, I think, in follow-up and surveillance, but it is important. Someone asked about siblings. Siblings, I worry about more. There's definitely a genetic link. A lot of that work's been done at Duke, actually. A lot of those genetic relationships, there's some genetic association. I have twins, and sometimes the whole family has Chiari. It's rare, but it happens. And unfortunately, I feel they become more symptomatic over time. And maybe it's because of genetics, but I do watch the twins very, very carefully over years. Both twins, actually. So if they're identical twins. So that's just something that the genetics, I think, do play a role, or genetic syndromes like Noonan's or something else. I've seen a lot higher risk of syrinx development, more tonsillar descent, becoming more Chiari 1.5, like things like that.
Yeah. A question in the chat that I want to touch on before we move on, just because it's pertinent. Do you find that symptoms in pediatric patients and adults are similar or different?
I think they're quite different, but I think it's more related to their lifestyle.
Sure.
And the kids are, obviously they might be in sports or gymnastics or doing bouncy houses or trampolines or roller coasters, and you're going to pick up trouble with Chiari. We pay a lot of attention to the neck and the whiplash strain on the neck. And those who know me, we talk about this a lot, in terms of long-term and restrictions. And the only thing I really care about is that repetitive neck motion, I think, does play a role. And we sure have had symptoms get worse after some inciting event, which is often a whiplash, low-speed car accident, the roller coaster ride, the trampoline, the bouncy house. All these things I have seen where all of a sudden Johnny has all these symptoms. And what did you do the day before? Well, I went on the trampoline or so. So those are real, and they do affect symptoms. So, but adults are very different, right? They're working, they're the family. There's a childbirth issue post-pregnancy that we see a lot of new symptoms develop, particularly headaches developing. There's a spine epidural may be done for pregnancy. We're very much in tune with that because of the potential CSF leak long-term, postpartum, that some of these women get, that they then develop a Chiari. And I always ask, did you have an epidural? Because then we got to look at that carefully, because it's a clear message of make sure we don't have a leak that could be quite hidden. It's occult. So, but they're very different. Adults also, it's more challenging because there's a lot more comorbidities in the adults. There's a lot more depression and anxiety and other conditions that make it even more difficult to say, are these Chiari symptoms, or or is this more intracranial hypertension? They're difficult to navigate than the child.
Sure. And then, so you talk about following twins as children. What about adults? Just as a quick follow-up.
Same. It's just rare in the adult side to see twins, in that setting, but usually I've already followed them from childhood. But I do watch them more, and I have more surveillance on those patients for sure, because I just don't know. And from my anecdotal experience, they get into more trouble that I need to make sure we are ahead of and not behind.
Sure. You talked a bit about the sleep situation. You talk about doing sleep workups. A question was, can Chiari cause severe obstructive sleep apnea? And I thought this was a good question. If so, where and what is that obstruction in the airway? And then as a secondary question, can this be related to the Chiari 1.5? Or 0.5 rather, should a sleep study really always be completed?
Yeah, I guess it also depends on the age, because try
Yeah.
getting a 5-year-old to do a sleep study. Not so easy. No one sleeps.
Yeah.
So I don't just recommend them, too easily, but sometimes the parents relate a really clear sleep problem, particularly the central apnea risk we're very worried about. If they have high syrinxes or really tight Chiari with brainstem sagging, say a 1.5, they can have pretty severe central apnea. Now, there are some studies done in Chiari 1 that it's more common to have obstructive apnea with the central apnea. So it's not so pure anymore. We used to say, oh, obstructive is all ENT, nothing to do with Chiari. Chiari is all central apnea. Not so clear. It's a bit dirty. But this comes from our Chiari 2 literature, which is also difficult, which is the open spina bifida. And they have some severe apnea concerns. And unfortunately, doing the decompressions for those kids, it doesn't just fix the sleep problem and the apnea problem. So we're worried a bit more about how the brainstem formed. And Chiari decompression is not going to fix that, right? And I wonder if that same thing is going on in Chiari 1. So we always tell the families it's often improved. You often have better or less central apnea and less obstructive apnea, but it may not just fix it. And that's because of how the brainstem formed. I always have ENT look at the child if there's obstructive apnea, because sometimes there's the tonsils and the adenoids, and they might get that done first. And that would often help the sleep. And that's a lot easier than going to the brain. So you have very close partners of sleep physiology partners. Usually pulmonary is the common sleep partner, and ENT, genetics, ophthalmology. These are our Chiari partners that we rely on.
So just a clarifying question, can you describe the difference between central and obstructive apnea?
I'm sorry, yeah. So obstructive, you can imagine, is more about an obstruction in your airway, like the big tonsils, and you're having trouble sleeping and you're obstructing actually your airway when you're sleeping because you're not guarding your airway. Central apnea is your brain is not telling you to breathe. And that's pretty scary, right? And that's why there's this worry at night with Chiari of documenting a lot of central apnea. A lot of these kids are on those sleep monitors, and it's a nightmare for families, right? There's things going off all the time. No one's sleeping for sure because they're scared, with that going off so often. So that's central apnea, where normally in between breaths, your CO2 would build up, and that's your trigger to breathe. But that doesn't happen if you have central apnea, and you'll have long pauses and don't take a breath because you're not conscious and control of that. You're asleep. So those are things we're more concerned. We're always watching the SAT monitors. You might need a sleep study to sort that out, right? It's much more sophisticated physiology we need to look at. And it's really nice to have one before and after. But I always wait about 6 months after. I think it takes that long to show that improvement. I don't want to do one at 3 months up. We got to do it again. Every sleep study is such a big deal to do. Families are not eager to get sleep studies.
Yeah, no, absolutely. We talk about this a lot, so I guess we can get to this now.
These are great questions. I hope someone's taking notes of these chats, because these are
Yeah,
fantastic
I know.
questions.
I'm trying to get to all of these too.
I would love to, look at later, and we can start, developing talks around these, because this is so important to kind of understand what people are really interested in, not what I was presenting. So.
Absolutely. I did want to ask this because this has come up in previous Q&As as well. Are ongoing headaches common and just part of life after decompression surgery for pediatric patients? Is that just something to be expected, or is that a sign that they need to go back to their doctor and talk to them about recurring symptoms?
Well, it's a complex question because it's a question like, did they have headaches before? Are they better? Are they occipital in the back of the head like they were before? Are they frontal headache? A couple comments. One, you can have frontal headaches that can improve after a Chiari decompression. It's in the 50 to 60% range, though, not the 90 some percent like the headaches in the back of the head. The reason I say that is we're not so exact in the science, right? That why does a Chiari cause frontal headache? And a lot of that we think relates to the spinal fluid flow. At least this is our theory, is that you have an obstruction outlet of the spinal flow, and that causes buildup of that pressure in the brain, that pseudotumor, the associated intracranial hypertension that has associated with Chiari. And that's that frontal headache. Because I see that after surgery sometimes, where we've now flipped a headache in the back to the front, but it's temporary usually, and it's because of this inflammation in the fluid. You're not absorbing it well enough after surgery, and they get a bit of a frontal headache, but it calms down. If you have headaches that linger, they could be unrelated or they could be pressure related. So these are the kids we may work up only if it's affecting their quality of life. That's, again, the key. If they're going to school, doing fine, or the adult's able to work through them, they're short-lived, we don't work those up because they're, like you said, I think they are part of the journey, unfortunately. But if they're disabling, if they're really affecting, or secondarily causing all the cognitive brain fog and all that, we got to investigate that further.
Sure. And then since we're on that now, two questions were related to that specific question about cognitive issues. So one, is there a connection between Chiari and learning disability that you know of or have seen? And then do you have any suggestions about managing those cognitive issues? So is there some way to identify if it's being caused by the Chiari or something else? Is that done by neurotesting? What do you recommend for? I don't know, those are two separate questions. Sorry about that.
It's a great question. It's a hour talk at least on this. I know we only have 15 minutes or so, so it's a tough topic. It's very difficult to prove that some of these cognitive symptoms are directly caused by the Chiari. The best proof you have is obviously operating on the Chiari, and the kid is doing a lot better, or adult. And we find that all the time, no question about it. It's more than just chance, that I do see improvement of many of those cognitive symptoms. But it's not something I promise because we don't know. And we have to be very careful of making that slippery slope argument. Particularly in, this has been studied, say, in the most extreme autistic behaviors, things like that, where there's some beautiful work done to try to see if they were linked. I've had patients where some of the autistic behavior was through the roof, or the ADHD was way off, or ADD. It didn't cause the ADD or ADHD, but the symptoms were now so far beyond, and their reserve is not high enough, and they get all these symptoms. You do the surgery, and it comes back down to the level it was before. So there's a relationship, but it's not causal, probably, of a primary diagnosis like anxiety, depression. But if you look at all the Chiari logs, there's a much higher risk of comorbidities with Chiari. Is that chance? That's what's difficult to understand because it's too much. There's too much there. And there's so many circuits between the cerebellum and the frontal lobe that they used to call the little brain in the back. It's not so little. There are amazing millions of connections that go all the way up to the top of the brain. And we're just not smart enough to make that causal link. So we need to keep pushing that science and doing a lot of before, after, careful neuropsych to understand that. And I did a lot of that at Stanford, trying to collect that prospective data very religiously. but it's a lot of work. It's about a half hour, parent filling it out, child, try to understand that because it's a bit dirty. Because here's the problem. I learned this in the military through all their concussion logs from my time in the Air Force that headaches, or problems in sleep can change all your scores. So that's already your bias in terms of if you have terrible headaches and you're not sleeping, you're not going to perform as well. Well, a Chiari patient has both. So that's the trouble with this, science is that we just can't easily link those unless we know more.
There are two questions that came in ahead, and I believe they're on the call, so I do want to get to them. An 8-year-old diagnosed recently. The surgeon says surgery is not necessary right now, but the child is having stool and urinary accidents. So is this something that could be related? Someone had suggested that they have the entire spine looked at. What would you do in that kind of case?
Well, like I mentioned, I would definitely do the whole spine at a minimum. We got to make sure there's nothing in the spinal cord going on all the way down to the sacrum. That can present like that and secondarily cause the Chiari. If there's no syrinx, then it's harder to really know, especially in the absence of any other symptoms. But if you had urinary and bowel, that would lead to years of urodynamic studies by urology to really document carefully, is there a potential tethered cord, a cold tethered cord? That's a more complicated diagnosis to make. But imaging is the number one thing for sure. I would hope that has already been done in that kind of child at 8, because that's when we see the changes because of the rapid growth. After 6, the rapid growth of these kids is when you start having a lot more symptoms. And if they're bowel and bladder, I'm much more worried about a syrinx or spinal cord problem below that is then dealing with the Chiari secondarily.
And then another question, a patient that's 4 diagnosed recently after, I guess, hitting their head on a countertop. So, it's again one of those incidentals, but the patient's having muscle spasms in the legs. So is that something that could be Chiari related, or are you going to probably give me the same answer as the last question? Out of curiosity.
If it's a real Chiari, meaning it's tight and we've screened the whole spine and same story, we probably would follow that kid, because growing pains and, those are real issues if they're late in the day, right before sleep, and they hurt, and the kids can be really symptomatic from that. We wouldn't want to do surgery probably for just that. But that kind of kid, you got to be careful because you don't want to miss a syrinx developing. That can cause a lot of sensory changes that can cause things like that I've seen as a red herring. Oh, it's just muscle cramps or, but it turned out to be a syrinx. So it's something that would require probably ongoing surveillance as opposed to, well, probably not related, call us if there's problems. That probably kid I would probably follow.
Sure. Another question. If a patient's already had surgery, but never received that full spine MRI, just to kind of round out this conversation, is it still recommended that they get one? I assume symptoms are still maybe a problem if they're asking.
I think it's so important. And I think really because I picked up things over my career I just would not have expected. So I think if you're going to go the step of doing surgery, I always screen the whole axis before. I don't want to be surprised. And if there's ongoing symptoms, it could be related to something related down the spine. You always want to see if there's a syrinx there at a minimum. So I think personally, it's something very important, even post-surgery, because that means I was already worried about it enough that I operate on it. That would have warranted full spine imaging for sure. I think that's important.
Yeah. This is an interesting question. Can Chiari or CSF pressure issues end up causing a seizure activity?
Not that we know of, no. I mean, there are cerebellar fits or seizures that are extremely rare. that is not something that we would say or do to Chiari. Chiari can, though, cause something called drop attacks, where you can see kids doing this and they just sort of drop. And it's pretty scary to see. Afterward, they're fine. So it's not like a seizure where you have this post-ictal or post-seizure time when you're just off and not right for a couple hours. EEGs are normal, but these kids will just drop. And if you have a tight Chiari with a very high up syrinx or something, that's a warning. You probably need to operate on that kid sooner than later. I worry about those drop attacks, but that may look like seizures to someone. That's something that can be confused. But I would say Chiari doesn't cause seizures that we know of. No.
This is a good question that I know comes up at the neurosurgical meetings a lot, but are there any cases where you would shunt a syrinx? So if there's a 12-year-old has had 2 Chiari surgeries and neither, I guess, have made that syrinx go away, and now there's a lot of scar tissue. So is that a case where shunt might be reasonable?
A shunt in the spinal cord, it's called a syringosubarachnoid shunt, I think you're asking about, is definitely a higher risk procedure, and to me is last resort. And what I'm always going to go back to, Caitlin, is the patient having symptoms from that. That's a case I'm not going to be treating the picture, because I have to go through the spinal cord to put that shunt in. A Chiari decompression is very different. We're not going through the brain. We are decompressing the brain and trying to be as minimally invasive as possible in there and getting out to not set that patient up for long-term scarring and tethering back there. So I'm a minimalist on the inside because I don't want to stir up a lot of inflammation. But the spinal cord and the syrinx, much higher bar, because that's a higher risk procedure. You could often lose function by doing that because you're putting the tube into the spinal cord. You have to get it in there. And you often have sensory loss and some motor changes. And sometimes there's such a collapse of the spinal cord, you can have even worse symptoms, and you have to get through that over several months. So it's a big procedure. It's kind of a last resort if the patient's having progressive, say, weakness and pain, and the syrinx is still growing. The problem is always up here, though, usually, with the Chiari patients we're talking about. I got to make sure there is truly nothing else I could offer up there, such as a fourth ventricular stent or something else, because I just know once we go in the spinal cord, it's a Band-Aid, and I've already given up here. Sometimes you have to do that, but it's rare. I don't place those very often on purpose. I often would go back up to the top and try to do something more definitive.
Mm-hmm. Yeah, that's really good advice. There's a question about the long-term effects of surgery. So what are those, and what's the chance that more than one surgery would be needed?
The chances are actually low. I mean, it's in the teens in terms of having to reoperate. Most Chiari patients do well with one surgery. They're good to go. Now, that's not what you'll read on Google. It's a disaster, and I feel so bad, but it's really not the norm. But there is that miserable minority that have repeated need for surgeries. They get much more scarring. It doesn't mean the surgery was done any differently, but these kids or young adults or, they can develop a lot more trouble. And that's why that first decision to operate is the most important, because we could be setting them up for many other problems related to the surgery, the scarring, the Chiari, the pseudotumor, the instability, all sorts of things that could come up, that we really always go back to that first scan. And was that decision the right one to operate? And if I see someone the first time that has had 2 surgeries, I'm always going back to the beginning. Was this the right thing up front? Because these symptoms are still there despite the surgery. Was that the right surgery for that patient? These are tough discussions, and they're more difficult if, obviously someone's had surgery even more than once. It's even harder. So it's a challenge to sort through all that, but it's very important to try to associate these symptoms and make sure you're doing the right thing, because the risks only go up with more surgery. But I hope that answered your question.
It did, but the only other thing was, are there long-term effects to the surgery that need to be considered? I think we kind of discussed whether or not that's true, but
I would say no, in terms of they can lead a normal life. That's the goal, and I face this most often in the military or taking care of athletes. The goal is to get them back to doing what they love to do. And the surgery itself is not going to change that long-term risk. What I worry more about is up front, because the Chiari was so tight, they had a syrinx, or I'm worried about them on the field. The Air Force used to always say, one pilot I had to treat, and they asked, well, what's the risk if he ejects out of the airplane? I have no idea. But they're worried about the airplane. I found out much more, so it's a tricky business. We don't really know, but most of these patients do very well. There's no long-term risk of that surgery itself, in terms of changing their lifestyle, or, once they're healed, and we do a lot of work to get them there, him or her, I want them to get back to what they love to do. That's why we're doing the surgery in the first place. Quality of life is paramount.
okay. I'm going to get to a couple more questions, and I don't want to go too far over.
Right.
But
I'm just getting going here.
this is a good question. Isometric head exercises and resistance exercise, is that something you recommend for pain management? And is that something that patients can do at home? Should they go see a PT first?
Is this after surgery or just in general?
Have to assume after, but if you could answer both.
Yeah, I mean, after surgery, it's a common issue sometimes to have that kind of neck discomfort. And it's particularly, I find, in patients that are very deconditioned before. They have such bad neck strain and pain, their neck's so immobile and they're very stiff. And I worry about them. And I tell them it's going to be probably 6 months to get your neck conditioned again. Those patients need PT for sure. They need to be taught the exercises carefully, particularly side to side. I worry more about the up and down extremes. That seems to get Chiari patients into trouble, whether they've had surgery or not. The flexion extension is much harder and strain on the neck, but side to side and resistance is really important. And PT also needs to be experienced in treating people like this, right? They're often used to, maybe athletes or cervical, laminectomies, but Chiari is a whole different ball game. And very much, if you have other conditions like Ehlers-Danlos or some of these other conditions that cause ligament laxity, you really need to be with specialists that understand that disease, to make sure they're doing the right thing. Neurosurgeons are usually not getting along too well with chiropractors because of the neck manipulation, the quick change in positions of the neck. We don't like that. Other things for the neck and chiropractor, fine, but aggressive manipulation, even post-surgery, I found gets Chiari patients into trouble. So that would be my answer. If you didn't have surgery, you can do those things, sure. We want to keep you as conditioned as possible. Someone asked about flying, exercise, all that's fine. There's no data you can't do those things. But obviously repetitive whiplash of your neck with something could set you up and become symptomatic. But we want you exercising. We want you conditioned, swimming, whatever it is. That's important for so many reasons, way beyond Chiari. Obviously, cardiovascular fitness, aerobic work, etc.
Absolutely. There was a follow-up about, can you describe what a drop attack looks like? There's a little concern about it. Everyone wants to make sure that they know how to recognize it, and when the difference is between that and maybe just a fainting issue, something like that.
Yeah, it's hard, because you can get pretty dizzy and faint. I guess I'm thinking more in children because they get these drops, and the parents will often have a video. They're just playing and doing normal things, and they just drop to the ground. And that's something that is not normal, right? And they just get up like nothing happened. That's what's kind of scary about it to me. And those drops, I don't ignore those. I've do the workup, it make sure they're not seizures, but if they have a tight Chiari, I'll be operating on that kid for sure, because I just don't know what those drops mean long term, but they scare me to look at. They're not dangerous, we don't think, but they're just not normal, and they're probably linked to the Chiari. So I think it's something that you pay attention to. But that's the best I can describe. If you look up drop attacks, you'll probably see videos of them and that sort of thing.
Last question, and then I think I'll ask one more clarifying question about how people can get in touch with you. But this was, where was it? Oh my God, I just lost it. Okay. About failure rates of decompression surgery. So with or without duroplasty, what's being done in the neurosurgical world to kind of address those things, and maybe, I mean, obviously patient selection, but beyond that, how are we reducing those rates of failure in the future?
Yeah, that's a great question. I was afraid you were going to ask that, because not a whole lot, to be honest. The surgery for Chiari hasn't changed a whole lot. That's sad. It's an operation that we've been doing for many years. I mean, I've refined it over the years, and I have a gestalt of how big of a decompression do we need, but it's not an exact science. I can just say, oh, the decompression is always this size. It's really individualized to the patient. And it's really important on the way out to make sure we've decompressed enough, but we didn't over decompress, we didn't under decompress. Both those lead to trouble. Leaks are a real problem. So we're very particular in this Chiari world about how we close, what patches we use, what glues we use, what suture we use. All those matter. It's like a shunt. It's got to look perfect on the way out, or there could be problems. And when you get the problems is when the complications go up. If you have a CSF leak, you get much more scarring because there's mixing of fluids and blood and CSF, and that's trouble. You don't want things going in that pristine environment, inside. The patches, we published on this. It's an important what you use, and some use pericranium, some use these grafts, some use bovine products. As long as in your hands your results are outstanding, that's what matters. It doesn't probably matter if you use this or that, but in your hands you get great results with what you use consistently. That's what I would ask. And you don't want them to really do something different, because they're used to that and they like it for a reason. So that's the 2 cents on that, I think. But unfortunately, not a whole lot of difference. There's endoscopic stuff. There's things that we're talking about to be more minimally invasive, but the worry is that we're going to probably under decompress, and we're going to have more failures, or you just do more bone only and you have to go back, say 20% of the time, because you have to do an open decompression with duroplasty. With syrinx, we've looked at that, and to compare those two. But someone with headaches, tight Chiari, and do you have to open? We're doing a lot more with ultrasound. It's very exciting. I think that's coming in terms of a little more scientifically ways to understand that in the operating room. But it's still very premature, sadly, even though we've been doing these surgeries for a long time.
Yeah. No, that's kind of sobering, but
yeah, I know it's hard to hear that, but the operation is also a very good operation, and it works well most of the time. So that's the plus here. And there's patient factors that sometimes affect those outcomes, but the surgical technique is rigorous, and there's a lot of discipline around that for Chiari, and we take that very seriously. But I think beyond that, there's not a whole lot that we know that really we could do different up front to prevent those 12 or 15% from having to get redos. The only thing I feel strongly about, as I told you, is not to do too much on the inside because of the risk of inflammation and setting up more trouble. And that's, tonsillar, and what you do with the tonsils. That's another whole hour discussion we don't have time for, but
we can do that at a later date.
Yes. Part 2.
Yeah, definitely need a part 2 at some point. If we didn't get to your question, I promise we will get to it in a future session. But I did want to ask, how people could get in touch with you if they wanted to come to the clinic. Are you seeing adults and children or just peds right now? And basically how people can see you at Duke or wherever.
Yeah, I can just speak for Duke for myself, but I see kids and adult. I have partners now on this team. We're building a pretty large center that involves the craniocervical team, spine team. It's the hydrocephalus folks that are very interested in NPH, intracranial hypertension. It's the CSF leak team. It's the connective tissue work, Chiari, like I do. But I try to get you to see the best person that I think is going to give you the answers you're looking for if you're coming to Duke. But for me to see, I mean, the best way is to call my office, and I try to work through these and try to understand if it would be worth your while to come out for a visit. I don't want to waste your time. If you have questions, you can always email me. I'll try to help you with that. It's very hard to answer specific medical questions by email, but if you have general Chiari questions or something like that, I'm always willing to try to help. I'm here for you. I've always have tried any way I can to help allay, fears, anxiety about this condition.
And when you talk about doing that initial to see if you can help, is that telehealth or do you just talk to the staff?
It's mostly with the staff and through the whole intake process because you have to get the imaging, and it's more formal that way. And out of state is tricky. You can't really do formal visits. You have to be very careful with that unless you're licensed in the state, then it's no problem. But what I'm really trying to figure out is it worth you coming out? Because I'm so worried about bringing you all the way over to North Carolina. It's great basketball. Now it's great football.
Yeah.
But otherwise, it's a big trip, and I'm very sensitive to that, to make sure you're not just coming out if there's really nothing I would do different than your team at home. So,
Absolutely. Well, thank you, Dr. Grant. We'll make sure everyone knows how to get in touch with your staff on the website and everything. And I really appreciate you doing this for us. And I think we will need a part two. People are already asking for it in the chat. So we will talk about that at the time. But
sure,
thank you.
I'm happy to. This is a complex topic. I love talking about it, and I feel for you all. I mean, those who are on, I'm sure are concerned, and they have anxiety about what's going on and where things are going. And all of us, I hope, are here to help and try to do anything we can to maximize the quality of life and understand this condition better. And thanks to Bobby Jones for this kind of forum to allow this kind of chat. This has always been fun for me to do. So thank you.
Absolutely. Well, thanks everyone for joining us. So
All right. Take care.